Hi guys, sorry, just technical difficulties. We'll give it 1 second for people to funnel in, and then we'll get started.
Okay.
Thank you for coming and sharing with us.
No problem. Thank you.
I'm going to be short and sweet tonight. My name is Danielle Angelari, and I'm the Executive Director of NAMI Northern Illinois. We are an affiliate of the National Alliance on Mental Illness, and we serve Winnebago and Boone counties. We do many things in our region. We lead various support groups. We educate families in our community. We advocate by shaping public policy and programming for people living with mental illness and their families, actively fight stigma, encourage understanding, and really try to keep in the forefront of everyone's minds the importance of mental health care. And we provide tools and resources necessary for all of that. So this is actually our last little education program. We take it like a 2-month break in the summertime. So July, August will be a little quieter on that front, but definitely last but not least. We just had our annual event and it went wonderfully over at Forest Hills Golf Club. It was a lovely day besides the little bit of rain that we did have, but can't really change that. And then just do be looking out for our sand volleyball tournament and our retail therapy event, which will both likely be in September. I say likely because I haven't quite chosen the volleyball date yet. But if you are an arts and crafts person, please feel free to look through our website and you could register to be a vendor at our retail therapy event. But this evening, I would like to turn it over, Katie, Catherine, however you'd like me to introduce you.
Katie's fine.
Okay, we have Katie Mistler here from SwedishAmerican Center for Mental Health, and she's going to talk about the mobile integrated healthcare for behavioral health program pilot. Thank you, Katie.
You're welcome. Thank you very much for having me. As Danielle said, I am the director for the Center for Mental Health at SwedishAmerican. I have just started this role. I started in November, and I am very appreciative and very thankful to be a part of that SwedishAmerican team. We are doing a lot of great things for the community, and the Mobile Integrated Health Program is one of those good programs. I'm going to go ahead and share the screen. I just have a little PowerPoint that that will go through. So I apologize. Okay, so our mobile integrated health program, it started just started in October, but just a little background on what mobile integrated health is that it actually encompasses taking healthcare into the community. The model itself discusses about or talks more about, like I said, bringing that healthcare out to the community, reaching out to underserved populations, and just trying to essentially reach out. And it just makes it makes a broader, we get to reach more patients that way. There are different models. It can be comprised of many different healthcare workers. Ours in particular is mainly from the EMS paramedics and then an RN from the Center for Mental Health. They have been, social workers can be involved. I've seen some where physicians are involved and they are part of that mobile integrated health program. It all depends on what the goal is of the program as far as what kind of healthcare workers are participating. So kind of as I mentioned, ours is it was a pilot program that we started in October. Our specific team was an EMS person from the Rockford Fire Department and the Center for Mental Health nurses. We had 2 to 3 primary nurses that went with the EMS from the fire department and went out to visits and to see the patients in the community. how we chose which patients were in this program, or actually it's a voluntary program, but how we reached out was that we went and we looked at patients that had been to the ED frequently. We looked at frequent admissions to the Center for Mental Health, and within the fire department, we worked with them to look at patients that had called 911 and transported to the hospital frequently. That's how we kind of started our base and then started reaching out. And that was because we needed like a base for the program, and then our referrals kind of filtered out from there. So we recognized that there was a need in the community. And like I said, we partnered with the fire department, started the program in October, and now we are we're continuing with that program for the moment. So the current state then, just so that everybody is aware, this is a voluntary program. Nobody is forced into the program, and we do want patients to participate. So that's why we do ask them to voluntarily agree to the program. There's a consent form when they come in, and then it's usually about a 12-week program is what we've kind of structured to developed the structure. The first 6 weeks are weekly visits, and we actually will, like I said, we'll go to the patient and we'll visit at their home, or sometimes they have different meeting places. But the first 6 weeks are weekly visits, and we touch base with those patients. The second 6 weeks of the program are bi-weekly visits. And so altogether, there's approximately 9 visits, but I do want it to be clear that we do individualize the treatment to the patients. We meet where the patient's at, their needs, and individualize their care to them. And then at the end, we do have a little graduation and get a little diploma so that you can be proud of stepping through our program. So to kind of give you a gist of what we are doing in the program, these visits, like I said, they encompasses of an EMS from the Rockford Fire Department and an RN from the Center for Mental Health. That's our primary team. The good thing is that with the Center for Mental Health, we can incorporate other disciplines. So we've had social workers or therapists go with on a couple visits. We've had some of our peer recovery specialists go with and visit with specific patients. Like I said, meeting those individualized needs of the patient. Depending on that, we can incorporate those other disciplines into the visit. The big the scope that the big picture that we do when we visit is this is our time to provide education for patients. We let them ask questions about their diagnoses, or about their health, anything in their health, their medications. This is their time to ask, and then the nurses can really give that education. They can really talk about side effects. Even if a patient is starting to feel that potentially a crisis might be near, we can start talking through, okay, what would we do? We can support them. What would you do if there was a crisis? Who would you contact? And also then connect people with those community resources as well. Part of our program, we do have the ability to reach out and talk with other individuals to help people maybe get an ID, or just in general find any other community resources out there. I know we have helped people get IDs. We've talked with people, given them resources for housing. We've even talked about substance abuse resources in the community too. And like I said, part of that visit is we develop goals then with the patient, because our sole reason for being there is to help that patient succeed. And so because of that, within our visit, we have that patient set up short-term goals, and then a long-term goal for when they graduate from the program. Those short-term goals are, like we said, within a week's time, a really short-term goal, so that when we come to our next visit, we can start talking about what does the patient want to work on next. The other part to setting those goals is, like, we can connect up with the patient's primary psychiatrist or their therapist, And this is a new component to our program, but by connecting up with those primary providers, we're also able to help the patient meet their long-term goal. And it also lets their primary provider know what the patient wants to work on too, on this more on like the week. It's a short-term the short-term goals. So like I said, that's a newer feature that we're working on and have set up so that we can connect with those primary people. And then that also, like I said, helps that patient be set up for success, because their therapists and their psychiatrists know what they want then too, and then they can incorporate that into their sessions. And then, as I mentioned, the larger picture is that the Center for Mental Health from Swedish American, we're able to help support by providing those extra resources through a therapist or through a peer recovery specialist, to ride along and help with those visits too, if there's an individualized need for that patient. So the overall arching goal of our program is to really be that bridge for our patients. We want to take a proactive approach in patient care, and that's why we're going out into the community and trying to meet with patients in the community. We want to be that bridge between inpatient care to outpatient care. And like I said, really trying to set those patients up for success. Sometimes it's tough going from that inpatient, that structured environment, to then right back into the community. And so, like I said, we want to be that stepping stone and be that support for people, so that, like I said, they can be successful. They can be connected with those community resources that are going to help support them long term. And then also really getting them connected with their primary therapist and their psychiatrist and their primary provider too, their PCP, because those are going to be that additional support. It really does take a team, and that's what's important, is like we're part of that team to help guide the patient to a successful future. So I kind of mentioned in the beginning how we started with the patients and how we reached out to patients. We, like I said, we took those patients that had some frequent visits to the emergency room. They had frequent admissions. They might have called 911 frequently and were transported to the hospital. So, and we started with them, we reached out to them. And like I said, it's a voluntary program. So we reached out to see if people would be interested. And then how we continue with our referral process is seeing those patients that do continuously come to the hospital. Like I said, just trying to help connect them with resources. And most of the referrals are coming from the Center for Mental Health, or they're coming from the emergency room staff. We have Center for Mental Health staff in the emergency room that complete psychiatric assessments for patients that come in crisis. And they are able to connect people with our MIH program as well. The fire department also was helping with referrals. They, once again, were just kind of, as we started in the beginning, those people that utilize 911 or transport, we, like I said, we would go visit and just ask to see if they might be interested in the program. And if people were interested, then we would be that that connection and that, like I said, that bridge to get people to their primary and to those community resources. Like I said, right now we don't have an external, like the primary psychiatrist or the therapist. We don't have them feeding into that referral source just yet. We just started reaching out to those and having that as a component to our program. So that's something in the works as far as bringing those external sources in. So right now, like I said, the referrals are coming from Center for Mental Health and the fire department. I apologize. That was my slides for the moment. I do want to take a moment to ask questions, and I do want to put a disclaimer on this presentation. We did just find out this week that there might be a slight pause in the program, but I know what I can do is I can speak from Swedish American, because that's where I work and where my support is there. We as Swedish American are going to do everything we can to continue this program. We have to look at a few components because it is paused slightly due to there were some contract issues with the fire department. So I just need to take a look at that part and figure out how we can support this program. This has been a very beneficial pilot program, and that's why Danielle had reached out, and I appreciate that. And like I said, we just recently heard this, but I want you to know that I've already been starting to work on how we can sustain this program for the future. And then I do see that there is a question in the question and answer box, and it says, how does that HIPAA, correct me if I'm wrong, but you might be asking, how does it is there a HIPAA violation? Is that the question? So if I'm not understanding the question, okay. So we do have consent forms that we have our patients sign when they enter the program. They, like I said, it's a voluntary program, and we ask them if they want to enter the program. If you're talking about the referrals, they're, like I said, referrals from the Center for Mental Health. And we, like I said, we ask the patient voluntarily if they would want to be in the program. We mentioned the program. We had a little flyer that we could give the patients, and if they would be interested, they could contact us too.
There's a couple other questions in the chat box that I'd be happy to help with too.
Sure.
How do you connect the person? Is it with a phone and address?
We ask the person when they enter the program to give us their phone and their address, and that's how we connect with them. If they were referred from the unit, we would ask them, from the unit, and ask for their address and their phone at that time too, like I said, if they voluntarily want to be in the program.
And I think maybe a follow-up to that, how do you physically contact the person? Are they in the emergency department usually?
Yeah, majority of our referrals come from the emergency department or the Center for Mental Health. And so the nurse is able to ask the patient, if they would be interested in a program like this.
And then what towns does the program reach out to at this point? Is there a limit or border currently?
Sure. We were keeping it into the Rockford area. We did reach out to kind of like a Rockton, Roscoe area at one point. Those were a case by case to see and to fit into the schedule at that time. But and like I said, that was kind of an outlying case, but Rockford was our primary border, just because of the distance when how long it took to get people, especially during the pilot, how long it took to drive in between. Because we do give our patients about an hour and a half visit so that they can ask all their questions, and that they can, provide appropriate resources for the patient. So.
Would an individual who has graduated the program be able to re-enter the program in the future?
Absolutely. Absolutely. If a patient graduated, we would, and if something would happen that they would have to re-enter, we actually developed a structure for that too. So we took that into consideration, and we have a plan for that. The only time we would not follow up with somebody is if they say they do not want to be followed up, or if we would go and they are not at the address or the phone number that they gave us. But otherwise, anybody that would want to be in the program, we let them participate.
And then how long has the program been in existence?
So it started in October and and through now, so it's about 9 months.
Tammy, I'm not sure if you have a question, your hand's raised. And if so, are you able to type it into the question and answer box or chat box? And I'd be happy to read it to Katie. Someone asked, I have missed this earlier, or I may have missed this earlier. What funds this program?
So the funds are coming from the fire department and Swedish American. We chose to fund it independently at this time.
Thank you. Are there any more questions for Katie? Do you know cost per person?
So currently there is no cost to the patient. It is, like I said, it's a cost that we're putting out to provide the service, but at this time there is not a cost to the patient. That's a very good. I apologize. I didn't address that.
Sorry, I was curious if she means like cost to you guys per person, maybe, possibly.
Oh, so we the only cost. I mean, there's. I'm trying to think how to. There's not a specific cost per person, I mean, there is if we iron it out. We're looking at cost benefit for the patient and for the organization. That's what we were looking at. And more so we're looking at how can we help the patients connect with those community resources. And the biggest thing is how can we let them be successful in the community too, because frequently coming to the hospital for admission disrupts their life. And so like I said, we're trying to have people have independence in their life, and then show them how they can utilize their primary care, how they can utilize their psychiatrist, their medications, what kind of questions they could ask with their medications. And if they're not feeling that the medications are appropriate, how do you go about asking your provider for a different medication? And like I said, trying to empower the patient to advocate for themselves too, but we're there to support them along the way.
Where can we find resources that you would share if we do not quite fit this program at this time? And they would not like to go to the ER at this time.
Sure. So resources to enter the program, or?
I think that so they don't quite fit into the credentials of being involved in the program, but they're wondering, I think maybe just other providers possibly. Which I would be happy to help with.
I was going to say NAMI has some great resources.
Yeah, if you want to provide me with your email, I can follow up with you in the morning, Jenny. Actually might have it in the registration.
So I see that there's another question that says, is there any overlap with the co-responder program with Rosecrans and Rockford Police Department? Our lists are not shared at this time, I should say, but I imagine we do have some overlap in patients, and our programs are running separately at this time. Now we do have communication, and we know who's in the co-responder program, and so we have had communication back and forth about, if there was somebody in crisis. And to kind of refer back to the first question, it does remain HIPAA compliant. So, so if that communication did happen, like I said, it was it was compliant. So, and we have been reaching out and trying to form a connection with the co-responder team with the police department.
Thank you. Any other questions? These are good questions, guys.
Yeah.
Sorry, my dog's shaking around. If there are no other questions, Katie, do you mind if I share the slides with people from this evening?
No, that's fine. Mhm.
And maybe the people that have registered and couldn't attend tonight. And I
Sure.
will also share the recording of this if you don't mind.
Sure.
Yeah. And if people do come up with questions after this, can they reach out to you? Can they reach out to me and I can ask you?
Yeah, either way is easier, or whatever's
Okay.
easier is fine with me.
Okay, cool.
Yeah.
Thank you. I appreciate you for doing this.
No problem. Yeah. I hope the information was beneficial for everybody.
Definitely.
And
I
yeah,
mean,
any questions?
we talked about this earlier, like how do people access the programs if they don't know about them, right?
Correct. Correct.
So we appreciate it and I hope everyone has a good night.
Yeah.
Thank you very much.
Sorry.
Yeah. No, you're good.
Like I know our program is still in infancy stages, and I know like we have a limitation right now, just like I said, running into some negotiation things with the fire department, but I want you guys to know, like, we are trying our best to, and I'm going to investigate on how we can keep this going, because there is such a need. And Danielle, you're right. Like, I think there's some more growth opportunity that we can work on with the community in this program and in general. So I appreciate everybody listening and letting you know that, like, we're working on trying to get this a little bigger for everybody. So.
Thank you. You have all the supports from us. Oh, there's one more question. Did you implement this program on your own, or how did this get started? They missed the beginning.
Oh, okay. I apologize. I came into this role and the program had already been started. It was my understanding that Swedish American and the fire department saw a need for the community and got together to do this. I don't know much more beyond that. Like I said, it was a month in before I came to this role, and then we kind of took it and kept it going. So, and kind of revamped it to where it is today. But I know the need was there, and so that started the thought process for it.
Certainly.
I just don't know who thought of it first. So.
And we do have some thank yous. Just awesome job.
Well, thank you everybody for listening.
Of course. Yeah, and I will share all of this information with everyone again too. Oh. Okay. Would the hospital and fire department talk about how they got started? Would they share with others? Just like the process behind it, you think?
Sure, I can ask, and then maybe we can, is there like an attachment or something we can put to this presentation?
Probably so, yeah. I have everyone's email addresses from signing in.
Okay, I will ask that, and I will let